Ladies and gentlemen, intensive efforts are underway to get curative therapies in chronic hepatitis B. Currently, only a few biomarkers are available to monitor, predict hepatitis B disease progression and treatment response. As new therapies are become available, new biomarkers to monitor and predict disease response are urgently needed. For that, what are new biomarkers? We will get information from Professor Dr. Nasir Hussain Lak. He is professor and consultant gastroenterologist and hepatologist and researcher at SIUT Karachi. He has more than 120 research articles published in peer-reviewed journals. He is member of Middle East Society of Transplant, International Transplant Society, and American College of Gastroenterology. He is currently working as professor and head of department at Gastroenterology Department, SIUT Karachi. Professor Nasir Hussain Lak.
I'll be talking more about the futurology of the armamentarium, which will fine-tune our decision making about the treatment and prognosticating these patients' outcome as far as the current situation is concerned. We know that the quantitative hepatitis B surface antigen and HBV DNA are a predictive markers for liver disease, cirrhosis, and in some cases HCC. But again, there is a caveat in this information. Even though we treat the sustained viral response in terms of negativity of hepatitis B DNA and a seroconversion of surface antigen, we still develop HCC in these patients. As a poor man's thinking, we are just at the moment thinking of a functional cure which is attainable in today's knowledge, and the realistic function cure is still beyond our reach. The new hepatitis B markers, will they be helpful to achieve this in terms of the stability of response, the disease reactivation risk? Can it predict a long-term HCC risk, or there is a extrahepatic manifestation model we can make out of it, or a long-term monitoring we can do with this? So, as in a very recent outcome in terms of the surface antigen related knowledge we got in the previous years, made us equipped in terms of the easel step of taking into the future was the stopping rule. The stopping rule here is we need to have genotypes, we need to know the level of surface antigen to quantify it, and we can say that in this certain number of patients we have to stop this treatment is not working. So EASL has come a step forward to take this as their guidelines pattern. So is with the other dynamics in terms of HCC risk. So what we have with us at the moment, the transcription activity going on in the cellular level gives us one of the very important biomarker in terms of hepatitis B core-related antigen, which has been extensively worked and studied, and there are lots of data available with us. These are three antigens, and they are measured. There are 149 amino acid sequence has been studied, and the hepatitis B core-related antigen levels across the phases of chronic hepatitis B have been studied. Their level have been studied in terms of fibrosis, necroinflammatory activity, and association with the liver enzymes have been studied. There, neck to neck, the area under curve patterns have been studied, and the assay has been now developed for the quantification and the outcome. And Japan is the first country to include into its treatment models. So now these logs for hepatitis B correlated antigen have been there with us, and we know in certain condition what will be the outcome with the certain amount of hepatitis B correlated antigen. So if we draw some logical interpretation out of it, so there are associations between other biomarkers and hepatitis B correlated antigen as well. And there is a difference between hepatitis E antigen positive and hepatitis E antigen negative patients as well. So what is that difference? The difference of level, the detection. And if I go further, because this is a correlation of high cccDNA transcription activity which goes along with its quantification of hepatitis B core antigen, and with the model which we will see in future will be such that a young lady with a BMI of 22, with an ALT of 30, surface antigen positive, E antigen negative patient will have a hepatitis B DNA low level with a fibrosis of F2. Now we will check for hepatitis B correlated antigen in these patients. We'll check the levels, and we can predict that this patient, although Professor Maria has already advocated to treat these patients, will have increased risk of progression to cirrhosis. So this prediction gives us insight into the future, and we will start treatment, whatever treatment will be available at that time. So we will develop a knowledge base in which we see chronic hepatitis B patient. We will do a genotype on it. There will be genotype B or C. Then we will have with us this hepatitis B correlated antigen levels, and we will predict it that there is a risk in this subset of patient to develop HCC in coming future. So as to draw this knowledge base in terms of surveillance model, we will have a hepatitis B patient who had developed a sustained virologic response after treatment, but at the end of treatment we were having high hepatitis B correlated antigen levels, and we can predict this patient can develop HCC, and this surveillance in this patient can be individualized. So now I'm coming towards the second most potential biomarker which will become one of the important tools to predict certain things is HBV RNA. Sounds little difficult for us to digest because we have already been trained and listening hepatitis B DNA. What is this hepatitis B RNA thing? So this is a very important biomarker. The serum hepatitis B RNA, the pregenomic one, is a clinical marker for cccDNA activity. So it is again quantified. It is a quantifiable marker, and the main values with the surface antigen, the HBV DNA, they correlate. And here the activity, the association between the serum and intrahepatic hepatitis B RNA levels with liver histopathology in terms of grading and staging is being correlated and in a linear fashion. Here the outcome with the treatment shows decreasing levels as well. Now in future what we will see, we will not only see the outcome in terms of hepatitis B DNA, but we will see that hepatitis B RNA, which expands its spectrum of positivity broader than HBV DNA. So we will take decisions according to this biomarker. Again, we will see the risk of reactivations in certain patients considering the level and the log factor of this biomarker. And it has been seen that it again interacts and correlates in a different manner with the other biomarkers we have already with us. So the association of HBV RNA and the viral rebound after discontinuation of nukes have been studied. The number is less, but again, it's a very exciting data. Here, the endpoints of treatment with HBV RNA levels predicts the risk of relapse after stopping oral viral antivirals and HBeAg positive patients with seroconversion. And it is a very nice study and nicely done. If we consider this data, the number is good. The end of treatment HBV RNA levels predicts the risk of relapse after stopping the oral antivirals in HBeAg positive patients with seroconversion. So now the knowledge base of ours in coming future would be like we will tend to do HBV RNA levels in genotype A patients. Why? Because it would give us a strong correlation with the HBV DNA. But again, in genotype B and C, we will be doing HBV, sorry, it is a misprint, it's a HBV RNA, which correlates with the quantification of hepatitis B surface antigen. But it again gives us a bit of knowledge. We will take it to be a futile effort to spend money on somebody who has genotype D to have HBV RNA for any of the correlations, because there is a weak correlation in a genotype D to have between HBV RNA and HBV DNA, or per se the quantification of hepatitis B surface antigen. If we go further, the next proposed model would be that we will do in coming future HBV RNA correlation to hepatitis B DNA in hepatitis E AG negative patients. It sounds little weird because we're not tuned to it, but again in genotype A and D there is a weak, there will be a correlation in genotype A and D in the HBA AG negative patients, because these subset of patients are difficult for us to really predict what will happen. Same correlation between HBV RNA levels and quantifying hepatitis B surface antigen has a weak correlation in this situation. Now, we will identify certain number of patients who would undergo treatment, and there will be a declining pattern, a rapid declining factor of hepatitis B RNA in the initial 3 and 6 months treatment period. And this shows a very strong predictor of hepatitis E serum conversion and HBV DNA level. And maybe in this subset of patient, we would restrict to a treatment period which is to certain amount of time, maybe in a year or two, we will stop the treatment. So again, if we will be doing E antigen negative chronic hepatitis B patients in our practice will treat with pegylated interferon, as the patient would say that I need to be treated for a fixed amount of time. Then if there would be a rapid hepatitis B RNA decline, it will be correlating with treatment response and long-term surface antigen loss, which is our best possible outcomes now at this frame of time. So are we entering into the era of individualized treatment? Yes, it is exciting, and it is quite optimistic to have this news that yes, certain people, certain patients will behave in this manner, and we will be very happy to see a predictive outcome in these patients to have a good treatment outcome and a surface antigen loss. So there would be some patients in which raised hepatitis B DNA at the baseline and hepatitis B RNA titers at 6 months post-treatment. So we will associate this with the viral rebound, which is a bad outcome in number of patients, but we would be predicting this beforehand. So if I go further with the same tone, the hepatitis B DNA negative but hepatitis B RNA detected patients. So I'm again alluding to one of the very important treatment outcomes, like somebody who at the cessation of treatment, at the concluding part of our treatment strategy, have hepatitis B viral DNA negativity, but at the same time, if we undergo the hepatitis B RNA test, which shows detection up to certain log, at that time we can predict that this patient has to have 100% relapse within 3 years post treatment. The future decision making would require a negative hepatitis B RNA as a marker for ETR, end of treatment response. So it's quite exciting. It's different for what we think at the moment. It's quite different. It's diagonal to what we think today. And if we will be able to amalgam the different biomarkers, especially to take note of hepatitis B core protein quantification, then we'll be more educated in terms of telling what will be the outcome. So if I say that we will have hepatitis B correlated antigen, I have hepatitis B RNA along with the other traditional things, will I be able to be more wise to tell what is the outcome? Yes. And it can follow for a period of up to 10 years, what we have seen with the current knowledge. So to conclude, I would say that hepatitis B core antigen and hepatitis B RNA are emerging markers for diagnosis, monitoring, and prognosticating the patients of ours of chronic hepatitis B. B core related antigen is the best surrogate marker of intrahepatic CCC DNA. You don't have to take biopsy and work on it anymore. And hepatitis B core antigen is a predictor for HCC development even in coming future time. The hepatitis B core antigen can forecast post-treatment relapse and hepatitis B reactivation in those undergoing immunosuppressive treatment, which is a special group. And HBV RNA is the monitoring tool for treatment outcomes and relapse. Thank you.
Thank you, Professor Dr. Nasir Hussain. Hepatitis B core antigen and hepatitis B RNA are emerging biomarkers.